Hi, Dr. Sancy Leachman. How are you? Welcome.
I'm fine. How are you, Steve?
Good, good. So thanks again for taking the time to join us on the Beating Melanoma project. We have another world expert, Dr. Sancy Leachman, who currently serves as the chair for the Department of Dermatology at the Oregon Health and Science University. And in addition, Dr. Leachman is the director of the melanoma research program at the Knight Cancer Institute, which is a NCI designated comprehensive cancer center. And in addition, Dr. Leachman is endowed chair in melanoma research and chair of the Southwest Oncology Group Melanoma Prevention Working Group. In addition to seeing patients, working in the lab, and I know that Dr. Leachman have talked about this in the past, that you are very, very passionate. She's very passionate about fighting this war against melanoma, and she has a group called the War on Melanoma. And so we got a lot to talk about. So again, welcome and thank you for taking the time to talk to us.
Yeah, thank you. I'm excited to talk to you about it.
Yeah, one of the things I really want to talk to you about is this idea of genetic mutations, right? And as you can imagine, a lot of patients who have just gone through the treatment for melanoma, inevitably some of the questions they have is like, what are my risks for getting another melanoma? We always talked about there's a gene, the environmental exposure, and specifically UV exposure, but maybe we can focus first. What are the individuals, what are the risk factors that?
Right. Well, it's interesting that you bring it up that way, because to me, I don't really separate them. Everybody thinks about, a risk factor is having red hair, or a risk factor is having blue eyes. But the reality is that the reason you have red hair or blue eyes or light colored skin or a bunch of freckles or a bunch of moles is actually because of your genetics.
Exactly.
Right. Those are things that are constitutionally part of you. They're not something that the environment causes at all. They are your inherited a gene that causes you to have red hair, or two genes that have red hair. So there really isn't a distinction between them, but I just listed all of the risk factors that you're asking about, right? So if you've got red hair, blue eyes, very lightly pigmented skin, a lot of freckles, very vulnerable skin, if you burn really easily or tan really poorly, if you've got a lot of moles, if the moles that you have are larger than, there's a lot of them that are larger than a pencil eraser. If you've got the moles that look atypical, that kind of have a funny appearance to them. If you're immunosuppressed, if you have had a transplant or some kind of a condition that requires immunosuppression, that's another risk factor. If you have a family history of having had a melanoma, that's a risk factor. So there's, if you've had a melanoma before, so your very first example, I mean, what a great example, they want to know now that they've had a melanoma, what's their chance of getting another one? Well, it's 9 times greater than it would have been if they've never had a melanoma, right? So all of those are risk factors. I know that was a long-winded answer.
There's
a lot of risk factors.
No, there's a very good way of summarizing it, right? And then also, you and I basically see patients of what we call the same phenotype individual with lots of moles, lots of atypical moles. Once you get over like certain numbers, your risk factor goes much higher. And then you have a multiple sort of family personal history melanoma, plus lots of atypical mole, plus the red hair, plus the freckles. Now every time the number just sort of stacks up against individuals. But I know you talked about the genes, you talked about specific 2 genes that give the color. What are those 2 genes?
Well, one of the genes that's really important is the melanocortin-1 receptor, which is called MC1R, it's the abbreviation. And then another one that is important for eye color is the oculocutaneous albinism gene, OCA2. And so those are 2 that we know that are also not only associated with the amount of pigment that you make, but they're associated with the risk for melanoma. So especially MC1R, if you have, you can have a red hair gene that causes you to have sort of red highlights, or you can't really see it very well. But if you inherit a gene, a red hair color mutation variant, then that doubles your risk for getting a melanoma. And if you inherit 2 of them so that your hair is really bright red, then it quadruples your chances of getting a melanoma in your lifetime. So there's risk definitely associated with the inheritance of variants in those genes that lead to the vulnerability, but it makes sense. I mean, I think if you think about it, all of the genes, well, not all of them, that's not true, but many of the genes that we know that cause these risk factors also cause vulnerability to the sun, right? Because you've got red hair gene, it makes you more vulnerable to sunburn. Because you have lightly pigmented skin, you're more vulnerable to sunburn. And because you're more vulnerable to sunburn, you're more likely to get melanoma, right? It's that gene environment interaction, right?
Yep. Yeah, it's interesting that, one of the interviews I did was Dr. David Fisher. He's talking about MC1R, and those individuals make the field melanin, and they, upon UV radiation, instead of protecting it, and they actually release free radical that put you at more risk. And one of the things, and you are one of the experts in genes and everything else. I'm going to maybe push a little bit further. Can you explain to us, what's the difference between the germline mutation and somatic mutation? Those are the 2 words that people hear it sometimes. What are those? And maybe you can give us some example of those mutation genes in relationship to melanoma.
Sure. So germline, all that means, if you think about the germ cell means the sort of like the egg and the sperm, right? And so germline is something that is present in early on in those, one of those cells that then gets incorporated in all the cells of your body, because everything that you are is derived from that egg and sperm, right? So you basically, that means that if you test your blood, then it's in your blood cells. If you test your skin, it's in your skin cells. It doesn't matter where you go, it's in the DNA in every cell of your body. And those mutations are the ones that make you more vulnerable to getting melanoma, right? So those are like the CDKN2A mutation, BAP1 mutation, MITF mutation, ARF mutation. Those are the high penetrance susceptibility genes in the germline. Okay, so now contrast that. The other word you used was somatic, right? And those mutations are the mutations that happen in the cancer or in the precursor to the cancer and lead to the development of cancer. So in the case of melanoma, the precursor that I'm talking about is just a mole, right? But in moles, you don't develop cancer overnight. I mean, it doesn't just develop spontaneously. It develops after you get a progression of a number of different mutations that occur. And those mutations in the mole, those are called somatic mutations. And they're a different set of mutations, although the CDKN2A mutation that's present in germline is often a common mutation that occurs somatically as well. But there's another gene like the BRAF gene, that BRAF, and NRAS and c-KIT, those mutations happen somatically more often than they do germline, and they cause that particular mole to go bad. But that doesn't mean, that every cell in your body has the mutation. It's just that one, just that mole that is developing into a melanoma. Hope that made sense.
No, that makes a great sense. I mean, I think, you encapsulated, you summarized it so well. And I think maybe we should just take this opportunity to just explain a little bit about the BRAF, right? Because one of the treatment, the targeted therapy, the BRAF inhibitors, and is sort of targeting against that somatic mutation, and sort of, yeah. And
and it's very important because it's a very unusual mutation, the BRAF mutation, because it's so common. And in fact, it's present. That mutation is one of the ones that we think may be the first one that sort of happens before you get the other mutations that ultimately cause cancer. And so it's present in about 50 to 60% of just plain moles.
Yeah.
The BRAF mutation can be in just a plain mole, and then you get another mutation on top of it, right? And that takes it closer to a cancer, and then another mutation takes it closer. But what's cool about it, because it's so common, it's present so commonly, and it's a single mutation. So what they did is created a drug, right? A drug that specifically knocks out the cells, only the cells that have a BRAF with that mutation in it, right? So that's why they call it targeted therapy, right? Because it targets that little mutation that is in the bad cells, but not in the good cells. So the BRAF, but the problem is that the cancer cells are smart too, right? And they can evade the BRAF, but it turns out that if you do a BRAF plus a MEK inhibitor at the same time, right? Then you keep it from bypassing, and it's sort of out tricking the trickster, the cancer trickster, right? And you're able to keep a lot of people from having further spread of their melanoma just by treating with those two drugs that are targeting those bad cells that have that mutation in them.
I think you touched upon two very important points, right? I mean, I think one is just remarkable to think that, because the BRAF mutation associated with melanoma, just on the 600th position, you have one amino acid change and somehow just drive that clone of cells just progressing, right? And that's why if you target that specifically, you can shut that process down. Another thing, like I think you touched upon a little bit, and I just want to explain a little bit for the public out there, is that people think melanoma is just one type of cells, but in reality, within that melanoma, you have different clones, perhaps, right? So especially for metastatic disease, so you may go after that clone and knock it out, but then you've self-selected another set of clones, and now they can sort of grow and proliferate. So those are really great. And what do you tell people? Let's say someone who had a history of melanoma, right, and family history of melanoma. They ask you this question: do I need genetic testing? And maybe we can touch that a little bit upon that. Like, one is, what criteria do you set to refer a patient to a genetics consult for genetic testing?
And you're talking germline genetic testing now, right?
Yeah.
Yeah. So there are some criteria, right? Because hereditary melanoma in the germline, right? It's usually hereditary. So the reason it's I talked about it being in the egg or the sperm. The reason it's there is because it came from the parent, right? So it's hereditary. So you inherit these mutations usually. And that doesn't mean it's always that case. Sometimes you can have a mutation that happens when you're in utero, right? At the time of conception or in utero, and it's not inherited, and you're the only one. So you have both situations. And so when we think about who is a good candidate for getting genetic testing, what I look at is I look at their personal history of melanoma, right? So if they have a personal history of melanoma that has three or more, if they've got three or more melanomas, primary melanomas, and then I start to think, that's a little too much.
Yeah.
That it may be more than just sun exposure. It may be more than just bad luck. That may actually be that you've got. And so that anytime somebody has had three melanomas themselves, I always start the discussion about genetic testing. The other thing you want to look at is whether or not there's a pattern of inheritance, right? So you have to ask a family history. So you say, okay, are there any other people in your family? And of course, it has to be the bloodline relatives, right? It's not the in-laws. They don't count because they don't share genetics with you, right? It's only the ones that are actually blood related. But those, if you've got, again, my threshold is usually about 3, right? So for example, if I've got a patient who has a melanoma and it turns out that their brother had a melanoma and their mother had a melanoma, then that's 3. And that's enough to where, again, it crosses that threshold for me that I really think, okay, we need to start talking about genetic testing. But the other thing is, it's not only melanoma. There's some melanoma genes, some of the genes that predispose to melanoma when they have a variant in it. Some of those are associated with other cancers besides melanoma. And that's one of the reasons it's so important to ask a good family history, because, for example, I mentioned the CDKN2A mutation or P16 mutation. The people who carry those mutations, if they carry it, then they also have a high risk of pancreatic cancer. And you would never, you would never see a pancreatic cancer like you see a melanoma. So it makes screening those patients very important to make sure that you're catching it early before it's too late, because pancreatic cancer, again, is a very aggressive cancer. There's another gene called BAP1, and BAP1 also predisposes not only to melanoma in the skin, but it also predisposes to ophthalmologic, to ocular melanoma, and it predisposes to kidney cancer too. And so you want to be able to screen, and maybe some other cancers too, but for sure we screen. We have them see an ophthalmologist as well. We have them see do a renal ultrasound, so we know that nothing's happening to the kidneys. And so so when you're asking the history, if it crosses the level of 3 melanomas, for sure, but if you've got 2 melanomas and you have a pancreatic cancer as well, or if you have 1 melanoma and a pancreatic cancer and a neuroblastoma or something, or another kind of neurological tumor, that's 3. That counts as 3.
That's 3, meaning the personal, not just not bloodline relative.
No,
Personal.
even bloodline. So
Okay.
if my patient comes in and they've had a melanoma and I say, do you guys have any other melanomas in the family? And they're like, no, we really don't have any other melanomas in the family. I'm the only one with the melanoma, but I've got 2 family members with pancreatic cancer.
Mm-hmm.
You're like, okay, you need to be tested for a CDKN2A and probably some other genes as well, right? And or they say, well, I've had, because that's 3. But if you've had, okay, I've had melanoma and I had a grandmother and a mother that had breast cancer. Well, breast cancer is so common, right?
Yeah.
It's very, very common. Having a mother and a daughter have breast cancer, you might want to be tested for breast cancer, right? But it wouldn't necessarily make it melanoma. It's not a melanoma family. It might be a breast cancer family that you might want to check. But they start to add up, right? So if it's a common cancer like breast or prostate or colon cancer, I usually give them a half point. So like I want 3 points. That's what I want. I want to add up to 3 points to kind of give me a good enough probability, and maybe that's something worth talking about too, is what do I consider to be a high enough probability of having a genetic cause to be worth testing, right?
So let me ask you another question. So couple of questions. One is, let's say someone who has 3 melanoma, does it make a difference someone who is 75 years old versus 45 years old?
It does. I think it does. It does for me. I mean, this is sort of an art, right? Because every human being is actually different. And so even though you can make some guidelines, you don't want to make them hard, fast rules, right? Because if a person, if you have a, let's say you've got a guy that comes in 75 years old, like you said, 75, he's been a river runner, he's got red hair, he's got sun exposure, and he gets a melanoma at 75 on his face that starts as a little lentigo maligna. The chances that even if he had 2 of them, or even if he had 2 and his brother who did exactly the same thing has 1 too, and you add up to 3, the chances that that's going to be because they're inheriting a mutation is much lower than if you have a person who's a 25-year-old who comes in. she's got a mole on her back that's turned into a melanoma, and she's got tons of funny looking moles on her back. And she's got a sister that has another melanoma, and a family member that's maybe more distant that has pancreatic cancer. Okay, that's different. That one counts, even maybe at a younger age. You know, maybe you only have two, but it seems really, really risky because they just aren't falling into the pattern of it being an environmentally induced melanoma, right?
Yeah. Also, I think another very important point you touched upon is that, not all melanoma are the same, right? The lenticle malignant melanoma found on the face in elderly person, their biological behavior is totally different from, let's say, a melanoma on the back, right? And then this is mostly due to sun-induced, and the risk of the lenticle malignant melanoma spreading to the rest of the body, killing someone, is very, very low. It's just, that's why also this genetic component plays a role. And coming back to, you mentioned breast cancer. How does a BRCA gene have any, does the BRCA gene have, you mentioned BAP1, but what about the BRCA2 or BRCA1?
Yeah, the BRCA1 and 2, right?
Yeah.
And some people feel like maybe both of the breast cancer genes are associated with melanoma a little bit. Some people think, oh no, it's just the BRCA2. Some people say, oh no, it's just an association that's unrelated to a direct cause. And so there's a lot of controversy out there actually about how strong of a melanoma effect a BRCA gene has. So I don't think that we have a hard, fast answer on that yet. I do think, though, that sometimes in BRCA2 families, I've had several BRCA2 families who, carriers have developed melanoma.
Yep.
That happens.
Yep.
And it's not necessarily, I think there may be a susceptibility, right? So maybe there is a susceptibility, but it's not a high penetrance, what they call high penetrance, where if you inherit that gene, then your chances of getting a melanoma is about, like with P16, for example, if you inherit a P16 mutation and you live in an environment in, say, the United States, your chances of getting a melanoma in your lifetime by age 82 is about 75%.
That's pretty high. That's pretty
high. They call that a high penetrance gene, right?
Yeah.
Now, if you have just red hair, right? You've got a red hair gene that we talked about, right? And you inherit two of them, and you've got both of them. And by the time you're 82, your chances of getting a melanoma is not 75%, right? But it's not zero. It's not, it's higher. It's about 4 times higher than the average population, which would probably end up being about between 4 and 8%, right? That's a lot lower, but yet it's considered a low to moderate penetrance gene, right? But then when you put the two, if you were to stack the two on top of each other, the chances that you're going to get a melanoma goes way up, over 90%, if you've got both a P16 and an MC1R. So everything has to be taken, I guess, hopefully what I'm conveying is that everything has to be taken in context. We have sort of these general ideas about how detrimental the gene is, what organs it affects, and what other kinds of relationships it has with other diseases, right? But each person has to be considered an individual, really. You have to do it that way because there's so much variability from human being to human being, and everybody deserves that. They deserve a consultation with a genetic counselor that talks to them about all of the different elements of risk and what answering that question of the genetic background is going to tell them and why it's important, right?
This is, again, thank you for providing such a rich context with so much information. We touched about penetrance, multiple genes, play interaction between environment, all this information. But let's get down to some of the logistics. Now, let's say you send the person for a test. Is it a blood test, a tissue test?
So for germline, it's just a blood test. You go in and you get a tube of blood drawn, and they send it in, and they do genetic testing usually with sequencing, but sometimes they're using some other things as well.
So that's a pretty quick and easy process. That's good to know for the patient. And next point is, what can you do differently? Let's say if you found this mutation, right? And what else are you going to do other than, let's say, of course, let's say you're going to tell the family members get screened because of higher risk. What other things are you going to do? You touched upon a little bit, sending to ophthalmologists if you have that specific genes. And I believe it was the BAP1 gene. And if you're talking about getting screened for pancreatic cancer, if you have CDKNA2A. But what do you recommend for that patient particularly? I mean, in addition to, let's say, 3 to 4 months of routine skin exam with the dermatologist, what else can they do?
Yeah, I mean, I think that one of the things that we found in some of the research we did, which I think is pretty exciting, is that when we did genetic testing on people who had not had genetic testing before, and we were looking, particularly in this study, we were looking at P16, the CDKN2A. What we found was really remarkable, which is that once you've reported back their carrier status, once they know that they're a carrier of that mutation, that pathogenic variant, once they know that, they become more compliant with recommendations. So there's something about it. It turns a little cognitive switch in their brain that all of a sudden then they're more aware of their sun exposure. They use better clothing and sunscreens and all of those things to protect themselves from sun. They do more self-skin exams, right? They're more aware of their body. They're paying better attention, so they catch things early, and they're more likely to go to see a medical professional for a regular skin exam, which also helps them to catch things early. So on one end, part of the reason to do the test, I think at this point, because of this data, part of the reason to do the testing is to empower the patient to do better self-care, because it impacts their ability to really appreciate the consequences of not doing that. And that's the reason for that is unclear, but it's really interesting, right?
But
you're basically helping the patient to comply better.
But this is even more so than, so you're saying that having that genetic report, and you will give them more compelling reason to do those preventions and follow up, despite the fact that, the prior history of melanoma is not changing, not nudging them towards that photoprotection behavior. It's that report that actually sort of tipped them over. Oh, that's interesting.
Yeah, let me give you an example. Let me give you an example of this. So I had one patient who, he'd had 3 melanomas, himself. He was a P16 mutation carrier. He'd had 3 melanomas himself. His family members, he had probably had, 10 family members with melanoma. Several of them had died, right? But he was tanning in a tanning salon. Okay, he was tanning in a tanning salon. And I counseled him in clinic every single time. And finally I said, I think we need to get your genetic testing done for you individually. And we did. And the next time he came in, he had stopped tanning.
Wow.
And he was using self-tanner.
Wow.
And, and it was a remarkable turnaround. But what we saw, in this study it was controlled, right? I mean, it was controlled. Every single person in the group had a family history of melanoma. They all knew about melanoma because of their family history. They all had this genetic pattern, right? None of them had had melanoma yet. And they were all very, very similar at baseline in all of their compliance. But the ones that got the report back became more compliant than the ones that didn't.
That's amazing.
Right? I mean, it was a real study.
That's a real amazing.
It empowers people, right? It empowers people to do what they know they should be doing anyway, right? So it helps them overcome whatever that barrier is.
No, that's an amazing study. I mean, I think that's one of the benefit I've never really actually thought of. How much does it cost? Does insurance cover? And
But I didn't, there's more, I don't know
sure.
if you want to hear more,
No,
but
no,
there are
please
more
go on.
reasons to do genetic testing besides that.
Oh, but what are other reasons?
But, so one of the other things is, as you mentioned, you need to know how frequently to screen people with respect to not only their skin, but to any other cancer that they're susceptible to because of the gene, the bad gene that they've got, or whatever. It's not a bad gene, the variant that they've got, right? So, you know, we know what those cancers are and the likelihood that they're going to happen. And that helps us a lot to say, okay, this person needs to have screening for ophthalmology and renal and pancreatic, and this one needs breast and colon and whatever it is that they need based on those genes. And so that's very important because that's the real benefit of knowing the risk ahead of time, is preventing it from getting out of control, right? So the screening and the prevention is the basic reason for doing all this. And then I think what your point was is absolutely really important, which is that you know, if they've got it, then probably other members of their family have the same thing, but they haven't had cancer yet. And giving them that information before it happens can not only save their lives, but it can make them it can have impact on what they do with their lives, right? Yep. Do they become a lifeguard, a professional lifeguard, or do they decide to work in an indoor job? You know, I mean, I think that it's about choice, and it's about empowering people to have that knowledge as power, as a foundation for living their lives.
No, those are all very great reasons. So I was gonna ask, does insurance cover the genetic testing, number one? And number two is, if you found to have one of those variant gene that put you at higher susceptibility for developing melanoma, perhaps pancreatic cancer, other type of cancer, does that prevent that patient from getting, let's say, life insurance?
Yeah, those are really good questions. And it's very complicated because some insurances cover genetic testing, some insurances don't, and some do under certain circumstances if you meet certain criteria, like the criteria I went
Got
through.
it.
And so it's highly variable. And that's one of the reasons that I really like to go through a genetic counselor, because most genetic counselors, part of the program, after they've counseled and they've told them about the risks and the benefits and the costs and all of the different things that, you know, let them decide whether they want it. If they do decide they want it, then they help them with pre-authorization of their insurance. So that's a real relief from our clinic, right? To have somebody who can do that. And so that's the best way to do it. And I think that some people base their decision about whether to have genetic testing on how much it's going to cost them. And, you know, nowadays we don't usually just do one gene. We use panels, and we may talk about that later, but yeah. So the second question you ask is about insurance. And most people, I certainly, until I got involved with genetic testing, I didn't know this. But there's different kinds of insurance. Some insurance is considered sort of standard and something that everyone in society sort of deserves and is not a luxury. And there's other kinds of insurance that's considered to be more of a luxury item, and it doesn't fall under the same protections as regular insurance. So there's the Genetic Information Non-Discrimination Act, GINA. It's called GINA, and GINA it's a federal level act, and most states also have a similar law in place that prohibits the use of genetic testing information. It prohibits it from being used for employment. You can't ask about it. You can't fire somebody for that. You're safe. Same for health insurance, right? Nobody is allowed to discriminate upon you because you've got a variant that's a pathogenic variant. But when you talk about disability insurance and you talk about life insurance, that is considered sort of this luxury item. It's not a standard insurance. And so in that case, they can ask you about it. And if they can increase rates based on whether or not you have one of these mutations. The thing about it is that most insurance companies are very smart. I mean, it's all about, risk. They know more probably about risk than we do in these guys, because they've got so many millions and millions of data points. But what they really don't usually ask about genetic testing anyway. They ask about, have you had any cancers?
Yeah.
Right. Which are the same questions I ask. Or have your family members had any cancers? And if they have, then they have the same information that we do, and they know that there's an elevated risk. And so most people, and if you say that you haven't, you can't lie about it, because if you say that you don't and you do, and it's ever proven that you did and you misled them, then the insurance is null and void anyway. So you have to be truthful. They can ask you all the right questions regardless of the genetic testing anyway, but it can impact and it can call attention to the fact. And so some people hesitate to get tested because they're worried about that. And I think, it is one of the elements of consideration, and you sort of have to decide, where are you going to, maybe you want to get your insurance first before you get your genetic testing done.
That's a really good advice. Well, anyway, Sancy, we are running out of time, unfortunately, and we didn't even cover your war on melanoma program, and we didn't cover lots of other things, interesting things that you're doing, and we have to invite you back. Hopefully you can join us next time. And once again, thank you so much for shedding so much light on this entire aspect of genetics, testing, mutations associated with melanoma. Thanks again for doing this.
Oh, my pleasure. It was fun to get a chance to talk to you. I'm happy to come back another time.
Thanks again. Talk to you soon. Bye-bye.